Hi, everyone. Welcome to Room Now's ACR21 evening recap. It's the first day. It's the opening ceremony we've had today, and actually we've had a number of things happen this week. We're going to review with you what's happened up to this point, give you some of our favorites. I'm joined today by Dr. Sheila Reyes from the Philippines, Dr. Kathryn from around the corner in Dallas, and Rachel Tate from Florida. Good evening, folks. How are y'all doing?
Great. Hi.
Good,
Hey there.
So let's begin with, we're going to end this session with a discussion of the year in review, which was quite an interesting session today, but a lot of other things happened today. We had a keynote address, a presidential address, but there were things that even happened earlier this week. Kat, you want to tell us about some of those or things that you liked?
Oh, absolutely. So this was actually the very first year they did a global rheumatology summit. And in the summit, they had discussions about underserved areas where they can't even get access to rheumatologists. And the Dr. Zifa Day, she actually pioneered the first rheumatology clinic in Ghana, and she won the inaugural Distinguished International Rheumatology Professional Award. And it's incredible. I mean, the work that she's done, bringing rheumatology and the attention of, the plight of people who need care but can't get it. So she's done amazing work. And then not only that, they had like Dr. Alakija, who is the co-chair of the African Union Vaccine Delivery Alliance, talking about vaccine disparities in underserved countries. So I love the fact that they highlighted, like the areas that we need to focus our attention to. It shows growth. It shows a lot of growth for the American College of Rheumatology, and also where, if one country is threatened, all of us is threatened. So essentially, if we work together, we will help each other.
All right. Any Rachel, do you have any suggestions about things you saw that you liked before today?
I mean, I agree with Kathryn. I thought those stories were just phenomenal, and they really kind of shaped things for me. I also really liked radiology boot camp. I mean, maybe that's just because I have a father who's a radiologist, but I don't know, I even learned some new pearls and some new thoughts too. So I think in terms of prior ACRs, I really like the lead up to this one. I hadn't anticipated that as much as I thought I would, but I've really enjoyed what we've seen so far. So it's good.
Interesting session on women in rheumatology, was there not? Who saw that?
I did.
Yeah.
Oh my God. So, they call her Sheila, right? Dr.
Alarcon.
Alarcon. Yes. Oh, I mean, I tweeted this and it got a lot of reaction. They considered her a high risk hire. Why? Because she's female, she's young, and she got kids, young kids. So the fact that she is now a rheumatology giant, and the fact that they were gonna like bypass her, holy cow. I mean, just think about this. All right, if you're a trainee out there, don't take no for an answer. Give it all you got. Show them what you're worth. That's what her video taught me.
Yeah, she's an OG. I mean, she is just a dynamite. It's amazing to hear her story and to kind of think about how we've come so far, but yet we still have a lot to learn too. She's amazing.
Well, I'm pleased that the ACR is highlighting these discussions because they need to be had. The data is pretty clear about, number one, women taking over in rheumatology as far as, the workforce, and that there are a lot of issues, whether you're in practice or whether you're in academia, as to, fair treatment, equal opportunity, workplace issues and whatnot. This is all about our careers, and we belong to ACR because we want to be better at our careers and have advancement and be smarter and stuff. And so I'm glad that this group exists. I think we'll be seeing more throughout the meeting about women in rheumatology. Any other highlights before today that anybody wants to talk about? Sheila, did you see anything before today?
Yeah, I got interested in the clinical research part about COVID-19 issues and rheumatic disease. Professor Dennis McGonigal gave a nice lecture on immunothrombosis, and he explained, the difference between a true vasculitis and a vasculitis mimics, and how these are different these are different from, you know, like a true vasculitis and the milder forms of disease,
Mhm.
and also that of vasculitis mimic and the more severe forms, and how the I liked his term, the battleground, where
Yeah.
it's the alveoli that he kept referring to as the battleground. So that was also an interesting session, including the abstracts that were presented in that session. I think just to add to the Global Rheumatology Summit, I think it's a very it's one of the an important highlight of the pre-convention, in that, you know, it's not just focusing on the ACR, but also what's happening around the world with the different rheumatologists. And so I really was able to, to connect, because coming from another part of the world that has different different treatment strategies, and even other treatment options are not available, and how um, we can, as a one group, as rheumatologists, really help change the world.
Yeah.
Absolutely. And you know what? One of the things that came up was rheumatology for all. It's bringing rheumatology education to places where they don't have good teachers or professors or access to training. And I mean, I'm thinking about it like leave no child behind, leave no joint behind. You know, maybe we should coin something like that. But rheumatology education, like what you're doing now, Jack, it's just been incredible. Like how much we have paved the path forward to allow others to learn about our discipline.
Train
You
the
know,
trainers.
We become, during the pandemic, we've become very much a one world community, more so than we ever would have been. And I think that's a real plus to one, education, and two, the quality of care. All that happened, interestingly, under the leadership of our friend and mentor, Dr. David Karp, the current president, at least for another few hours. Anybody want to comment on his presidential address from today?
He's amazing. I mean, I've known Dr. Karp now for like almost 20 years. He actually trained me. He was my chief. And so, I interviewed him a year ago. I asked him, what are you going to do during this year? And he says, I'm going to work on reorganizing the ACR. I'm going to be working on diversity, equity, and inclusion. I'm going to be working on gender gap issues. I'm going to be working on education. I'm thinking to myself, wow, I mean, this is so much. But you know what? He delivered. He absolutely delivered. Even today, like in the keynote address, I mean, he just flipped things so differently. He invited this powerhouse of a woman, Dr. Seema Yasmin, who came on and interviewed her. I mean, if you knew Dr. Karp really well, it's like he's, quiet and, thoughtful. And to have him in front of this one woman who is just like so effusive, it's incredible. But it was such a good opening ceremony.
Yeah, that interview, I mean, what she had to say, and then that interview, which was very David Frost-like, very David Karp-like, really was both entertaining and highly informative. David asked the questions that's on everybody's minds. And what else did you take from his address today? Rachel?
I mean, I think in general, I have always appreciated the way he looks at things, and he had a tough job coming into this, as Kat denoted. Number one, he's in a powerhouse city with a lot of other powerhouse people. Dallas was highly represented today. And I think I just appreciated, especially that interview. I mean, that interview was amazing. She is incredible. And overall, what I really took from that is the spirit of reboot and the kind of empathy that we should have, not only for our patients, but for each other. And this understanding that while we don't know everything, specifically, this was in regard to COVID, but realistically, we don't know everything. So we have to continue on this trend to teach each other. And so we are the best for our patients. And I think I always get that from him too, from Dr. Karp.
Yeah. Sheila, what did you get from Yasmin's keynote address?
So first thing, it was okay, it was a very interesting twist to your regular keynote lecture. And so I was really like listening in, because she was really a very eloquent speaker as well. I mean, you know, but before I give comments on Dr. Yasmin, for Dr. Karp, I like what he said in the first part of his speech, where he said that ACR convergence is where rheumatology meets, and he used four words: collaborate, celebrate, network, and learn. And so, ultimately, these are the things that we're doing right now. Of course, including enjoy. I think that's a very important word, and have fun. So yeah, the Q&A session between Dr. Karp and Dr. Yasmin, it was very inspirational. It really took me when Dr. Yasmin talked about communication as being one of the most frequent procedure in medicine. And I think it reminds us that, despite all that's happening with the pandemic, the virtual engagements, it boils down to good communication, important communication, not just between physicians, but between physicians and our patients and the community.
Yeah.
And you know what? I'm sorry to interrupt, Jack, but one of the points that Sheila made and that highlighted in Dr. Yasmin's speech is that physicians, we need to learn how to present information to the public. We need to be savvy with social media. We need to be able to talk to other people, educate them, and not just be behind a door writing prescriptions. That's not us anymore. As doctors, we are the face of medicine. We are science. So we have to learn how to do it in an effective way that it's going to allow people to not misinterpret data and yet drive science.
Well, in her comments, go ahead, Jack.
No, go ahead.
I was going to say her comments regarding social media, Kat, to that extreme, about how we have to be really very cautious about what we put on social media. I mean, we talk about this all the time from a Room Now perspective. We want to share good, appropriate information, data, et cetera, with everyone, right? You're sharing it with the world, but we've got to stand up and actually make a fight for what we want social media to look like, not have it be driven by advertisers and vendors. We have an opportunity to have a voice, and in a varied voice, and we need to be able to do that. And I thought that was really well stated. And I mean, she's just a powerhouse. What an incredible history.
Yeah, that I want to just clarify for the audience, that latter point was David asked her, what does she think about social media and the potential for bias when you're, throwing out sound bites and whatnot. And she really said that, there's a lot of things about it, but that there is a potential for misleading and that there needs to be safeguards and whatnot. And I think that we worry about that a lot at Room Now, because we do teach in short form. And the good news is that we've got a large audience and we get a lot of feedback. I put a tweet out there about interchangeability and the first drug that has an interchangeability label, and I was a little bit misleading. And Angus Worthington, he challenged me on it right away, both personally and then on Twitter. And I think that needs to happen. We need to hold each other to the facts and speak to the facts and try to avoid, the opinions, which can be kind of one-sided. But Kat, your point about, being good at communicating, I think that really was the feature of Mike Brenner's Year in Review. Mike Brenner is a great scientist. He's known for high quality work. He had the hard task of giving this largely clinical audience the top citations in the field in the last year. And what did he do? He won on each of the citations. He told a little bit of a story, a little bit of background. Here's the paper. Here's what it means. And then at the end, when he was done, he wrapped it all up and he reviewed what he just told you. So if you were someone who doesn't, subscribe to JEM and JCI and and the Journal of Immunology or whatever, you probably learned something just by listening to Mike Brenner. So let's talk first about the basic science year in review. Any highlights for any of you? Rachel, do you want to start?
Yeah, I mean, I really thought it was interesting that we discussed IL-1 and osteoarthritis. I don't know if anybody else thought that was amazing, but I don't actually remember a year in review that has included OA before. Can you guys think of one?
Single largest, greatest unmet need in all of rheumatology. We should be talking more about osteoarthritis.
Yeah, that was my main highlight, I think. He did an excellent job, but that I was like, oh, I really tuned in and was kind of like, interesting, tell me more. And how does this work? What is the mechanism? I thought that was the highlight by far for me.
Yeah, I mean, being pivotal in what happens with cartilage degradation. Kat, did you have one that you liked?
I love the fact that, he's saying the future is going to be engineered cells to control inflammation. Like, whew, mind blown. Forget about injections, forget about pills, engineered cells.
Yeah.
What's the stock for that?
Well, we wrote about that on Room Now a few weeks ago. It is a very cool sort of approach, taking basically engineered cells that you implant in a scaffold and then what you do is you implant cells that are programmed to sense something, in this case, inflammation. And then once it senses, then it delivers an anti-inflammatory therapy that's engineered and built in. So in this case that they used, there was the delivery of IL-1RA as an anti-inflammatory approach when inflammation that was very cool. I still is, and I don't know that a lot of people understood that when we wrote about it a few weeks ago, but I'm glad that he made that one his top citations. Sheila, was the one that you liked?
Same with Rachel. It's the IL-1, and I also like the fact that despite being a celebrated scientist, he really included and mentioned in the last part of his slides that he actually apologized for not being able to include some of the other articles or researches that were also important, but due to the time limitations. So you see how here's a good scientist, and then you see the qualities of being a humble researcher, and how he was able to simplify things. For example, for a doctor like me who's more of a clinician than a basic basic scientist. So it gives you more perspective. It keeps you listening in on the topic. So it was really a good talk.
Yeah, I like that he sort of reviewed sort of the discovery of Vexus and the ubiquitin and UVA1 X-linked association with an autoinflammatory syndrome. That was sort of a highlight from last year's meeting that now is in publication, and therefore was worth mentioning. And then I like that he mentioned Virginia Pasquale's work in New York. Virginia Pasquale's a longtime collaborator of Kat and I, and she's got this great way of showing where the alpha interferon comes from in lupus. We always knew it was we thought it was mostly from plasmacytoid dendritic cells under multiple influences that were giving rise to interferon as one of the main drivers of lupus. And if you're interested in that topic, Peggy Crow is doing a Klimper lecture, I think, on that in a few days. But she shows that these retained mitochondria in cells is another big time driver of interferon alpha. I thought that was really kind of cool. I didn't even know that Virginia was working on that. So congratulations to them. And there are many collaborators. If you look at the author list on that, Virginia includes everybody that she's ever worked with on these projects. She's very generous in her authorship on these very important papers. So any other highlights from basic science, or shall we move on to the clinical stuff? Let's go to clinical. So Karen Kostenbatter did a really fabulous job of reviewing a lot of things. She reviewed the Avacopan FDA approval, the Aurora 1 trial, the tofacitinib, a JAK inhibitor in ankylosing spondylitis, the whole disaster that is the 1133 oral surveillance study and safety concerns behind JAK. Great news for JAK. Wait a second, not so great news for JAK. The Arctic Rewind, a step down study, if you will. The Tycho Spa, the tight control and spondyloarthritis, knee OA, step exercise, and then disparities. And then she ended with, she ended with COVID.
COVID. Yeah.
That right there is about 2 hours worth of work that I think she put into the 30 minutes. What was your highlight? Let's begin with Sheila.
Well, my highlight was more of the, having to receive or get positive results from the trials, such as that of the Aurora one. We know that there have been a lot of clinical trials in lupus, but the results are not as positive. And so we at least have, some light into the end of the tunnel
Right.
with lupus, and also I like how she presented the data with the different studies, the Arctic Rewind study, although of course along the way you would also think of questions as to whether, like, for the Arctic Rewind, why would patients in remission have to be the difference between stepping down or tapering down and compared to giving a stable dose if you're DMARDs.
Let's go back to voclosporin though. The Aurora trial, that's a lupus nephritis trial. They did better because they had a clear-cut endpoint, and that was a complete renal response and UPCR and whatnot. They had like double the placebo response, 41% versus 23%. That was great. And that, like you said, that's important in lupus trials. Voclosporin's new. And then she was asked questions about how will you use this with, mycophenolate and other drugs. And of course, it's brand new and we don't know. Kath, do you know the dose of voclosporin yet?
So it depends on your renal function.
No.
And so,
I'm trying to stump her, and now she's going to teach me about voclosporin. Let's go past the stumping part and let me give us your impressions of voclosporin results.
So I do have to say that I participated in the study during the clinical trials, and it's actually a very impressive drug. I've prescribed it before too, recently to my patients where they were so refractory and we needed something to add on. And so it's a great add-on drug. It really is. I mean, it is expensive, but one of the things that I agree with her was the fact that, like compared to tacrolimus, I mean, like, are we paying a lot more for something that can do the same thing? But then she also mentioned that, the toxicity, the side effect profiles of voclosporin is going to be so much better than tacrolimus. You don't have to monitor levels. Mm-hmm. So that is definitely a convenience. But my patient so far has tolerated the drug really well. I'm going to continue to prescribe it as it's available on formulary. I think that there's a place for it. Absolutely, particularly if it allows my patient to get off of steroids.
So is there a place for avacopan?
Are you asking me or you're asking somebody else?
Well, I'm asking Rachel. It's it's FDA approved. It had some problems at the FDA hearing. It was sort of a split dose. It didn't really meet its primary endpoint, and it doesn't really show a safety advantage over the steroid arms and how it was tested. And it's $150,000 or more a year. So is there a place for avacopan? What do you think, Rachel?
I mean, I think you're asking me the right question, but I'm going to answer the question that I want to answer, which is yes, of course, there is a place for every drug because there's going to be a patient that will benefit from each of our medications. I mean, I think that's kind of the spirit of what I've learned from 2021 in general. I absolutely think there's a place. I agree with you. There was some dissension amongst the FDA, especially with only one trial that brought this to head. But yeah, I mean, we need another win for our patients with vasculitis, just like we needed another win for our lupus nephritis patients. There's going to be an opportunity for at least one of my patients to go on avacopan and be a success story. So yeah, I absolutely think we needed it.
Okay. Rachel, what was your favorite from the clinical topics that Karen brought up?
Well, initially I thought I was really going to like the avacopan and getting her kind of ideas on where she would use it for patients, but I really enjoyed the COVID information. I mean, number one, the amount of information that we have some amazing rheumatologists working on, it's just incredible. Like just the evolution of everything was really exciting. Yeah. That was
Yeah.
mine.
She highlighted the MISC and then the two
Okay.
large studies with differing opinions about IVIG and that. Maybe the US is right. Looks like a better done study. And then the deaths from the Global Rheumatology Alliance that a bunch of you out there are participating in. Kathryn's participating in 300 plus deaths. I want to make this statement. And, from that study, we know that some of the risk factors for bad outcomes with COVID amongst our patients are fourfold higher risk of death and bad outcomes with rituximab. But you also do bad if you are on sulfasalazine. You also do bad if you are on a JAK inhibitor and steroids and abatacept. I wouldn't have expected a lot of those things. This is my take. I don't think it's those drugs. I think it's the patients that go on those drugs. I think if you're on sulfasalazine, you're largely not being treated. And I think the patients who do well in the era of COVID are patients who are well controlled, well treated. If you're on steroids, you're probably in trouble. And the higher the dose, it's always a bad risk factor. But patients who go on JAK inhibitors and maybe abatacept and certainly rituximab, they tend to be our worst patients. They're not your first, second line, or usually best controlled patients. And we do know activity is a strong factor. Age, is a big factor. Obesity, comorbidities, but activity of our immune disorders is so I'm not willing to indict all those drugs. Does anybody want to disagree with me?
I'm going to say I disagree with you for Rituxan, because patients on rituximab really don't respond with their humoral immunity. I mean, they have lower levels of antibodies. That's been demonstrated by Al-Kim. So I agree that the patients who require steroids, who require rituximab, yes, they're at another higher level at risk. But I think the drug itself with rituximab definitely could contribute to the mortality and morbidity that has been seen.
Yeah, we do. I would also recommend avoiding rituximab in patients who you're worried about COVID and whatnot. It's a bit of the data seems to be repeating itself there.
Maybe that's where we use Avacobin.
Yeah, maybe it is. I mean, again, a good example of a potential opportunity.
All right. Well, that's a Sheila, do you have another? You brought up the issue of the Arctic Rewind, which is a very interesting study, and it really underscores this idea that we probably shouldn't be withdrawing therapy on our patients. And 92 patients, they were in DAS remission. You either continued your therapy and they had both TNF inhibitors and conventional DMARDs. You either continued your therapy or you half the dose, and the half dose patients just didn't do well. Is this how you practice, or has this changed the way you practice?
Well, particularly because it's coming from a different part of the world where it's only just, for example, methotrexate that's more affordable or more available, and we don't have a lot of biologics available in our country. So so the results would tell you that I'm doing this in some of my patients, and it gives you insight on whether, okay, I think I really need to just maintain it on a stable dose, as long as you regularly follow up your patients and they're compliant with their medications, and also managing expectations. A shared decision making between the patient and the physician is very important in the management of our rheumatic diseases. And so I think it plays the Arctic trial, the results of the trial gives importance into considering what patients should be on should be tapered or just maintained on stable dose, as long as you check or you regularly follow up for side effects or for other for increased flares, I think.
Yeah. We're at the end of the session, but I want to end with Kat. What do we have? Anybody has any questions for our panelists? You can write them into the chat section. We'll try to get to them. But Kat, do you have any closing remarks on the opening day?
Now I'm looking forward to the rest of the meeting. There's some really exciting stuff that's going to happen, from the great debate telling me how I'm going to manage my lupus nephritis to plenary sessions, because there was a plenary abstract that talked about how over the last 20 years, lupus nephritis deaths had actually gone down. So that's actually very, very exciting updated figures. So I'm just looking forward to the rest of the meeting.
Yeah, I'm going to be looking forward to 1133 oral surveillance study, multiple abstracts on that. That's going to help us navigate the future discussions on JAK inhibitors. Rachel and Sheila, what are you looking forward to in the days coming up?
Well, I just kind of want to bring up one thing. There's a master in our midst, guys. I don't know if you are aware. Dr. Cush was awarded a Master of the ACR. So I'm pretty excited about that. But to answer, oh, what are you going to show us? Oh,
I don't have a crown, but I can wear a mask on top of my head.
Look
And
at
I
your
should write
crown.
master on top here for throughout the meeting, see how that goes.
That looks like a bra, Jack.
And that's the end of that. Okay.
But
Thank you for that.
honestly, it is a huge award, and we're humbled and we're grateful for you and everything that you've done in terms of rheumatology education, both personally and of course for everyone else. But I am looking forward to ACR 2021. There are going to be a lot of great abstracts, including some plenary sessions on psoriatic arthritis and AS, which is my area of interest and expertise. So I'm looking forward to that. Sheila, what about you?
Yeah, I'm looking forward to another exciting virtual experience, despite the huge time difference. Um, I'm learning lots, and I'm looking forward to listening in on the plenary sessions, the abstract sessions, and even the posters on lupus and axial spondyloarthritis. And also, I think it's interesting to look into the community hubs, particularly for me. I'm also interested in education, and so yeah, lots of things to look forward to.
Yeah, the plenaries tomorrow are interesting. Risankizumab and PSA, lupus nephritis mortality in the United States. The ARIA study, which is an abatacept preventing RA in at-risk individuals. Blood-brain barrier issues in lupus patients with cognitive dysfunction. And
that's a plenary, yeah, that's a plenary.
Yeah, these are all plenary sessions. And then how immunosuppression affects antibody titers in our patients who get the COVID vaccine. So I want to thank the panel for viewing in. I hope that all of you will tell your friends that we're going to keep doing this every night, Saturday night, Sunday night, Monday night, and Tuesday night, 7 p.m. Eastern time. It's going to be the ACR recap featuring the Room Now faculty. Thanks, everyone. Take good care.
Thanks, Jack.
Thank you.